which is uniting against diabetes and obesity. So these aren't just numbers on chart or lifestyle statistics. So every rising blood sugar level, every extra kilogram has a ripple effect on the heart, on the arteries, and ultimately on lives. And to discuss more on this, I would like to call up on stage our speakers, Dr. Professor Aditya Kapoor, Head and Department of Cardiology, SGPGIMS, Lucknow.
Welcome, sir. Thank you so much for making it here with us and to share your insights. Let me also welcome Dr. Professor Hemant Madan, Senior Director and Program Head for Cardiology, Narayana Hospital, Gurugram.
Dr. Mohit Dayal Gupta, Professor of Cardiology, GB Pant Hospital, Delhi.
Dr. Satyavir Yadav, Associate Professor, AIIMS, New Delhi. And we will invite Dr. Manisha Khurana, Founder for Next Edge and Editor-in-Chief for VOH, to kindly moderate this session of extremely eminent panelists.
And let me acknowledge our session partner for this is Novo Nordisk.
Thank you so much. Dr. Khurana, the stage is all yours, ma'am.
Thank you so much.
Welcome, ma'am.
And as we have come to know that diabetes and obesity are no longer just metabolic conditions, they are at the core of India's cardiovascular crisis. Today, we'll explore how innovation, prevention, and collaboration can reshape the nation's cardiometabolic health. So, my first question goes to Dr. Aditya. Sir, your RHD ROCO program has shown how community models can improve heart health. How can similar preventive frameworks be used to tackle diabetes and obesity, especially in rural India?
Hi, thank you so much. It's a privilege to be here. So I'm glad you mentioned the RHD ROCO program. We launched this in collaboration with Stanford Design and Edward Life Sciences. The prime aim is to sort of try and eliminate RHD from UP. And it centers on 3 pillars: prevention, awareness, and community engagement. So I think I strongly endorse, and I'm sure everybody would agree, we can replicate such models to fight the epidemic of diabetes, obesity, or diabesity as it's called. And if I need to sum it up briefly, I would probably say that the first core thing which we should replicate from this model is community engagement. So, you can empower your rural or urban community to educate them that how bad is diabetes, how bad is obesity or overweight. Educate them, make them aware. And a corollary or an outshoot of this would be local capacity building. So in RHD ROCO, what we have done is we have roped in the RBSK workers, which is Rashtriya Bal Sevak Karamchari Yojana. So we have empowered them with questionnaires to screen for rheumatic fever, and AI-enabled stethoscope which just picks up a normal or an abnormal murmur. So I'm glad that Mohit is here. He's a great fan of AI. So these guys are armed with stethoscopes and questionnaires, and similarly on those lines for diabetes, obesity, community health workers, Anganwadi workers, they can be educated, taking a BMI, taking a waist hip circumference, measuring blood pressure is not a big deal. So once this happens, the third thing which is going to happen is an attitudinal or a behavioral change of the community. So they will understand, the bad effects of diabetes, as I said, overweight, obesity. Once they understand that, these programs cannot be standalone. So they have to be integrated in our already existing government schemes, government welfare plans. And once we have these, we'll have some self-sustainable models. So again, the key word is that I don't think diabetes or obesity will be fought in hospitals or clinics. They'll be fought in towns, villages, kitchens, homes. And the bottom line again remains that prescription for these diseases is zaruri hai, essential hai, but participation of the community is mandatory. So that is how this is going to happen.
So I believe that community participation is all that is required, and AI-enabled stethoscopes are really helping us. And again to you, Dr. Aditya. Why do you think diabetes and obesity are often called cardiovascular diseases in disguise? Why do you think that diabetes and obesity are called cardiovascular diseases in disguise?
So again, very, very insightful. So I believe that if you see diabetes and obesity, they are probably cardiovascular diseases which are wearing metabolic masks. and they leave an indelible cardiac footprint. If you look at the numbers, numbers are staggering. We have the dubious distinction of being the diabetes capital of the world. Obesity, paradoxically, we think that Indians, obesity, overweight would not be a problem, but again, the numbers tell us a different story. We have an Indian phenotype, which is the thin fat Indian, or a mono variety. There's a recent publication, metabolically obese and no obesity. So we become metabolically obese at lower BMI cutoffs because our visceral adiposity is different, the percentage of visceral fat is different, insulin resistance is there. And all of us cardiologists see that for patients of diabetes and overweight, diabetes is phenotypically not very obvious. It's a silent disease. Obesity or overweight is phenotypically visible, but the people are not aware of the bad effects. So that is the slight difference. But if we understand that these are diseases which can suddenly present with first cardiac event, we saw so many people who come with heart attacks, high blood pressure, heart failure, and then we detect that they are diabetic or they have a bad BMI, they are metabolically obese. So once we understand that these are cardiovascular diseases, the paradigm is going to change. It will change our policy, it will change our practice, and we'll be able to detect these patients at a much earlier stage rather than once complications have occurred and the brunt of the damage is already done. So they are absolutely, I agree, cardiovascular diseases, no doubt.
So they are the silent killers, and it's the time, we must address them. So Dr. Mohit, your work in Norin's STEMI registry gives deep insight into real-world cardiac events. What does current events show about how managing diabetes and obesity can reduce heart risk?
So, thank you so much. Today is a time for customized care. We have to move beyond using Western models. And let me tell you that we did a simple registry and we collected 6,000 patients of acute myocardial infarction. And to my surprise, 44% of them were having a BMI more than 27, they were obese. 35% were diabetics. And when we followed them up, they are more likely to have more hospitalizations for heart failure. They are more likely to have a shorter lifespan. They are more likely to have a poorer quality of life. And what we did was we just allowed them to have 5% decrease in this weight, nothing more than that, and manage their hypertension properly. You would be surprised, within a year, their mortality, their morbidity decreased, the quality of life increased. That is the importance of simple transformation. India, we have to understand, it's a country still of poor people, of middle class people. The care is not available to everyone. If it is available, it is not accessible to everyone. And if it is accessible, it is not affordable to everyone. So to have a great care, we need both availability, affordability, and accessibility. And due to this, we conducted this registry. Simple transformation, lifestyle, movement, changing their dietary patterns. We designed simple diets, trained them to move. They are not moving. We told them just to move for 1,000 steps, 3,000, 4,000 steps. That is what is decreasing their mortality. You would be surprised, by almost 14 to 15%. So it is important that we take care of these.
Rightly said, sir. Exercise is very important, and these are lifestyle diseases, and we must
Let me put one way. You would be surprised, moving 40 minutes every day. If you are moving, that is adding 40 minutes of great life to your every day. And if you are not moving 40 minutes every day, you are decreasing 40 minutes out of your age every day, this quality of life. This is what research shows. That is the importance of movement. That is what our country, our government is saying, that everybody should move with steps at least 4 to 5 to 3,000. Doesn't matter 10,000, but you should move. That is very important.
Now we have the registry for SEBI and the data which you have got. How can such registries and national studies guide better treatment and prevention strategies for these comorbidities as well?
I'll tell you. You see, we still are working. There are so many seniors and friends who are sitting here. You ask them, you would be surprised and shocked that to predict mortality in Indian patients of heart attack, we are still using foreign models like TIMI scores. What we did was we designed our own AI-based model in collaboration with the IIT. That is known as a Merck model. The predictability of patient dying because of these risk factors using Western data was equal to sensitivity around 60%. But when we used our own model, the predictability was 80 to 85% in only 6,000 patients. We need to validate it more. That is where the role of these registries is important, because Indian patients and Indian population, in fact South Asian population, is behaving completely different. So we need to have customized tools, we need to have customized approach to manage these patients. So it is going to give you a real world granularity. आपको ज़मीन दिखा रहा है कि भैया ये चल रहा है यहाँ पर. You don't just believe on what Western data is showing. Females are less likely to seek care. Females are more likely to die. Females are less likely to come to the hospital after MI and seek healthcare manifestations. Do you know that? This is what our registries are showing. And that is why now we are using, even comparing Western preventive tools with on our Indian data, and you would be again surprised the sensitivity is less than 50%. So we need to have a customized approach to manage these patients.
So diversity is also one thing that should be addressed through registries.
Definitely.
Right. Dr. Hemant, from your clinical experience, what experience you have gained from your clinical practice, strategies can help manage diabetes and obesity-related cardiac complications in diverse patient groups?
Well, this is going to be a repeat of what Dr. Aditya and Dr. Mohit have already said. The question is actually similar in a different format. Taking off from what Dr. Aditya said, I think community education and community engagement is still extremely, extremely important. Making them exercise, making them test themselves, making them understand that they are diabetic before a complication strikes them. You know, it's very, very easy to detect an engine failure after an event has happened. But the trick is to identify this in community before complications happen, before a cardiac complication happens. This is not a nephrology forum, but one more risk factor or one more risk complication of diabetes is kidney failure. So before these things happen, it's better to identify diabetes. There are several tools which we could apply to get this through to community. We all get our report cards when we are students, in the school. I don't think any report card in India still mentions BMI or still mentions their sports capabilities. I mean, you all get medals, but it's not annotated. So, these are simple tools. Alert teachers would kind of, prime you to this. The first time that an Indian undergoes a health examination is either when he's seeking a job or sometimes even later. So we need to, diabetes is happening earlier, heart disease is happening earlier, so we need to kind of analyze this earlier. So there are several things, but each community needs to, and it cannot be the duty of healthcare providers to do this all by themselves. We are not that large in number. Our penetration to general public is not that high. So I don't think as a community of doctors, even paramedics, even all the private hospitals, government hospitals put together will be able to educate. So the community has to have this, and it has to have a cascading effect. So eventually it all boils down to community penetration of education and awareness.
And there is, I think, stigma around this, and getting patients to view obesity and diabetes as a treatment and as a strength and not as a weakness is very important. Anything you want to add, sir?
Oh, absolutely, absolutely. I mean, awareness that they have disease and acceptance that they have disease. For some reason, in our Indian context, we are not brought up to take ownership of health. We are not brought up to take ownership. Just to give you an example, if a person drops a glass, हम लोग क्या कहते हैं हिंदी में, ग्लास गिर गया. अंग्रेज क्या कहता है, I dropped a glass. He takes ownership, right? He says, I dropped the glass. Whereas हमारा glass गिर गया. It doesn't happen on its own. So the point I'm trying to make is that unless you take ownership for what you're doing, the kind of lifestyle you're leading, and this concept of, कि बच्चा बड़ा healthy है. It's a very common concept, no? We shy away from saying that a child is obese. We say, nahi ji, ye healthy hai. All these little things, they need to go out of our customs. They need to go out of our understanding, and we need to actually, I don't know if there's a word called numericalize, but we need to give a numerical value to all these things, and then only, suppose you see a BMI of 31 in a 12-year-old baby, in a 12-year-old child, then you understand, okay, he's obese. You say healthy hai, it doesn't drive home the point. So that's the point I'm trying to make.
India में healthy होना अच्छा माना जाता है.
Yes.
So, but we need to take the ownership. So, Dr. Yadav, how do you see that lifestyle diseases are straining India's healthcare system, and what policy intervention or incentive models could make preventive care as our mainstream?
So it's an important point for Indians' health policy. Obesity is increasing way higher than the Western population. If you talk about the National Health Family 5th survey, Dr. Hemant said that in India we used to say that the child is healthy, those who are obese. It's because if you talk about 2 decades earlier, the percentage of obese population in child and adolescent was only 2%, and it has increased around 4-fold in last 2 decades. In child and adolescent, it's around 8% now, and if you talk about adult population, it has grown from 8 to 9% to 20 to 25%. So there is around 20 to 25% of our adult population is obese. And one important difference if we compare with Western population is that for them the BMI more than 30 is obese, but for us BMI more than 25 is obese. So we have a slightly different structure from Western population, and our people initially they used to be malnourished. The malnourishment was the main issue for Indian health structure, but nowadays in last 2 decades the obesity is become a pandemic for our country also. So if you talk about the policies, there are 3 important schemes from Government of India. One is the National Program for Non-Communicable Diseases, and if you talk about the medication and the treatment of these, there are some policy for treatment. One is PMJ Yojana, and another is the Jan Aushadh Yojana, by which we can get medications for these patients, especially in the government sector.
Right. And one important point from you, sir, that how can India integrate cardiometabolic screening into existing public health programs like Ayushman Bharat and National Program for Prevention of Cancer, Diabetes, Cardiovascular Diseases and Stroke?
If we talk about cardiovascular disease, there are simple, small movements like Eat Right or Fit India movement. Nowadays, we see there are a lot of PSUs are also involved in the marathon running. Their main purpose is to aware the people about the obesity, and obesity is a multiple effect. If we try to decrease the weight, it will reduce the hypertension, it will decrease the HbA1c, it will definitely decrease the cardiovascular outcomes. So if we decrease the weight, then we'll get rid of multiple problems. We'll get rid of joint problems, we'll get rid of multiple cardiovascular risk factors. So reducing weight is definitely have multiple impacts, not only on the cardiovascular health, it has shown effects in the GI diseases as well as cancers also. So there are multiple effects of weight reduction.
So I want just quick liners from all of you, whatever comes to your mind. My first question is to Dr. Aditya. Which single lifestyle change has the biggest impact on reducing cardiovascular risk in patients with diabetes and obesity?
So I think Dr. Mohit already mentioned. I would say maybe 30 minutes of brisk walk every day, because walking is one important thing which is often missed. It's a very, very powerful tool, often underprescribed, and if I could bottle physical activity into a small bottle, it would outsell every cardiac drug. So that is the important thing.
Right. And Dr. Hemant, if you had to choose one emerging therapy or innovation for diabetes or obesity that could revolutionize cardiac outcomes in India, what would it be?
Does it only have to be a therapeutic?
Yeah.
Oh, that's very difficult. That's extremely difficult. you know, because there are lots of new drugs on the horizon, but I mean, I would any day bet on non-therapeutic, non-pharmacological maneuvers as a treatment rather than pharmacological maneuvers.
Right.
So,
Okay, that's a good way. Dr. Mohit, which group is most at risk for cardiometabolic complications, urban, rural, or elderly?
Urban middle-aged people are sitting on a ticking metabolic time bomb. This is because of their poor lifestyle, sedentary habits, addiction to technology, consistency, and processed foods. So this is one of the population that is really in an alarming state.
Again, lifestyle. Dr. Satyavi, digital tools and apps, are they helpful or just a hype?
So they are definitely helpful, but extreme use or addiction to these tools, we might lose our intellectual inputs to the management of cardiovascular disease. But definitely they are helpful, but we should not over-rely on these apps.
All right. Dr. Aditya, one policy move that could most effectively reduce diabetes and obesity-related heart diseases in India.
So again, if I have to choose one thing, I would say policy should now prioritize prevention over treating, or prevention over procedures. So one policy could be integrating preventive healthcare schemes right into the basic infrastructure, so that even a small unit as a PHC becomes like a cardiac health checkpoint. So that would probably change cardiovascular outcomes.
Right. So attacking at the roots, sir. Dr. Hemant, sugar sweetened beverages, ban, tax, or educate?
education.
So with that, I think I conclude this session, and I think we should address heart disease not in isolation but collectively with diversity. Thank you so much.
Thank you so much, ma'am, for moderating this session exceptionally. And thank you to our esteemed speakers for this session and amazing insights you guys have shared. Now, I would like to invite Dr. Manisha Khurana to please come on stage and felicitate your co-panelist. Dr. Aditya Kapoor. Let's have a round of applause. Dr. Hemant Madan.
We extend our gratitude to Dr. Mohit Dayal Gupta. Thank you so much for sharing your insights through this panel, sir. Dr. Satyaveer Yadav, we also like to thank you, sir, for sharing your insights through this wonderful panel. Ladies and gentlemen, could I interest all of us to give in a big round of applause to this wonderful panel and the insight that they shared with us through this one. A very relevant topic indeed that was touched.
Now, I would like to invite Dr. Naveen Nishchal to please come on stage and felicitate Dr. Manisha Khurana for exceptionally moderating this session.